Bismillahirrahmanirrahim. Assalamu alaikum. A 15-year-old girl is brought to the office due to irregular menstrual periods. Manraki was age 13 and since her period have been irregular with cycle varying from 3 to 8 weeks. The patient has no chronic medical issue, has never had surgeries and take no medication. Her mother and older sister have polycystic ovarian syndrome and both take oral contraceptive. The patient has never been sexually active, vitals are normal. Physical examination show normal hair distribution and TNR stage 4-5 sexual characteristic. Abdominal examination is normal. There is dark red blood noted at the cervical os and no active bleeding. Serum prolactin and TSH are normal. Administration of micronized oral progesterone result in withdrawal of bleeding in 3 days. Pelvic ultrasound reveal normal ovaries and uterus. Which of the following is the most likely explanation of this patient irregular menstrual periods? So this patient is 15-year-old girl. She is brought to the office due to irregular menstrual period. Mendraki was at age 13 and since then her period have been irregular with cycle varying from 3 to 8 weeks. Physical examination show normal hair distribution with TNR stage 5 and secondary sexual characteristic. There is a dark blood noted at the cervical os. Administration of micronized oral progesterone result in withdrawal of bleeding in the next 3 days. Based on these, here the correct option is choice D, insufficient gonadotropin releasing hormone from the hypothalamus. So insufficient gonadotropin secretion, the initial menstrual cycle in adolescent are irregular and anovulatory. The abnormal uterine bleeding that follow menarche is due to immaturity of the developing hypothalamic pituitary gonadal axis that produce inadequate quantities and proportion of gonadotropin releasing hormone and subsequently FSH and LH required to induce ovulation. Menstrual cycle lag their regular periods. The endometrium builds up under the influence of estrogen but without the influence of progesterone. The cue to slough the endometrium is lacking and menstrual-like bleeding occur due to estrogen breakthrough bleeding. Normally, progesterone is produced in increased amount by the corpus luteum following ovulation and withdrawal of this progesterone as the corpus luteum degenerate result in menses. Come to the incorrect one, androgen excess. So as we already know that androgen excess are characteristic of polycystic ovarian syndrome. Estrogen deficiency. So estrogen deficiency can result in secondary amenorrhea, which typically present with are characteristic of primary ovarian insufficiency, typically present with secondary amenorrhea. Excess LH secretion. So excess LH secretion is also a characteristic of polycystic ovarian syndrome. Choice E, intrauterine adhesion. So as already I explained in the previous question, intrauterine adhesion, which is also called the Sherman syndrome, and which there is a secondary amenorrhea due to the adhesion between the endometrium due to previous surgery or something instrumental use.